Ta vel imot kandidaten og komiteen. Reis opp.
Good afternoon, and welcome to this public defense of the thesis entitled Predicting Anterior Cruciate Ligament Construction Outcome, Machine Learning Analysis of National Knee Ligament Registries. Today's candidate, Kyle Martin, completed his thesis in December 2024. Based on a proposal from the Department of Sports Medicine, the Research Committee of Norwegian School of Sports Sciences has appointed the following committee to judge the thesis and other requirements for the award. Professor Jorunn Sundgodt Borgen, Norwegian School of Sports Sciences. Professor Kristoffer Barfod, Department of Clinical Medicine, University of Copenhagen, first opponent. Assistant Professor Jacobin Osterhoff, University Medical Center Groningen, Department of Orthopedic Surgery Groningen, the Netherlands, as second opponent. The committee has concluded that the thesis meets the standard worthy of a public defense for the award of Doctor of Philosophy, PhD in Sports Science. Earlier today, the candidate has given a trial lecture with the title Treatment of Recurrent Patellar Instability and the Role of AI. Is it time to go all in, or is less more? And the trial lecture has been found satisfactory by the examination committee. I would now like to ask the candidate to introduce his doctoral research in the form of a short lecture, and the opposing members in the examination committee to engage in the candidate in a defense of the work. Should members of the audience wish to ask questions relating to the research, I ask to bring these in written form to the attention of the chairperson in the break prior to the second opponent's questions. Okay, then I ask the candidate to take the place at the lectern, please.
Can you hear me okay? This is working? Excellent. All right, I would like to begin just by thanking the Norwegian School of Sports Sciences for allowing me to defend my thesis here today, along with the review committee for taking the time out of their busy schedules to be here today and for the thoughtful review of my PhD thesis. I have no relevant disclosures. I also want to acknowledge funding that we receive for our studies. Initial funding came from the Norwegian Arthroplasty and Knee Ligament Register in Bergen, as well as the University of Oslo. And then we obtained subsequent funding from a Norwegian Centennial Chair seed grant. I also want to thank all my co-authors in Norway, Denmark, Ontario, and Minnesota, along with my mentors and supervisors throughout this journey. So as a clinician, and I am a clinician first and foremost, every day we're called upon to make decisions on diagnosis and treatment management for our patients. And then we base this on patient factors and as well as our own experience and understanding of the best available evidence and literature. And all of this information that we collect enters our personal algorithm, and we decide on what we think the patient's diagnosis is and how best to proceed to achieve the goal of optimal patient outcome. And this is part of that art of medicine and navigating that gray area. Over the last several years, there's been an increased focus on outcome prediction, and this is largely driven by artificial intelligence and specifically its branch, machine learning. Machine learning is basically advanced statistical techniques that allow us to model complex relationships between variables in a data set to try to predict an outcome or another variable. This is largely automated with minimal human programming, and the computer learns over repetition and repetition through the data to generalize. The basis of my thesis is on the prediction of outcome after ACL reconstruction using the national knee ligament registries in Norway and Denmark. The premise is that patients oftentimes want to know what their expected outcome is after surgery. However, the complex interaction between all the various risk factors, and these are only some of them, that contribute to the risk of a poor outcome makes accurate outcome prediction challenging for the clinicians. The Scandinavian knee ligament registries have collected a large volume of data since they started a little over 20 years ago and represent an ideal starting point to explore a machine learning approach to outcome prediction for these patients. And the underlying hypothesis was that machine learning analysis of these registries would enable us to estimate a patient's specific risk of failure. So overall, the purpose was to apply machine learning techniques to the registries in Norway and Denmark to evaluate for the factors that most allow us to predict or most associated with outcome, and to predict the risk of a poor outcome at the individual as well as group levels. Additionally, we wanted to create some clinically useful tools that could be valuable for surgeons to guide their discussions with patients. Following a stepwise approach, this thesis is comprised of 6 individual studies or papers, the first 3 of which are related to model development. Papers 4 and 5 are external validation of the developed model, and the 6th paper is a different approach than the first 3 papers in that it applies unsupervised learning, and I'll explain the difference. So I'll start off just with the first 3 papers, the model development papers. And so for paper 1, the primary purpose was to apply machine learning to the Norwegian ligament registry to identify the most important factors associated with the risk of eventual revision surgery, as well as to develop a clinically useful model for predicting ACL revision at the time of primary reconstruction. The registry had 25,000 patients with a primary ACL reconstruction between the years 2004 and 2018. Again, the primary outcome was revision surgery, and we did it at 3 time points, so 1 year, 2 year, and 5 years. The data was split, and we split it into a training set comprised of 75% of the data and a testing set for 25. So you basically develop a model, train it using 75% of the data, and then you test it to see how well it performs on the remaining 25% that the model has not seen yet. We used 4 models, and all models were well calibrated with moderate discrimination at 0.67 to 0.69. It came down to needing only 5 factors out of the various that were inputted into the model to predict outcome. This enabled the development of an online risk calculator, which based on those 5 variables, here's an example patient, 20-year-old patient having a hamstring tendon autograft. And you can see that this patient has estimated 1 year, 2 year, and 5 year risks relative to the median right here, higher risk at all time points. If we use a different patient having BTB instead, you can see it's much closer to the median. The second paper was very similar to the first. The only thing that changed was the outcome of interest. Instead of predicting revision surgery, we predicted subjective failure of primary ACL reconstruction. And subjective failure was defined as a KOOS quality of life score, which is one of the subsections on the KOOS patient reported outcome measure, a score less than 44. Again, primary ACL between 2004 and 2018. 4 models were trained and tested after appropriately splitting the data again. And this time for this one, 10 factors were required for outcome prediction. Another example here, inputting the 10 variables. And we can see this patient's estimated risk of achieving failure is pretty low. So 8.1% compared to the median, which was around 18-ish%. Change a few factors in the model again, and you can see how it will spit out a different risk prediction for a different patient. So add in a cartilage injury, previous surgery on the same knee, and you can see that it's a higher elevated estimated risk. The third paper was combining the Danish with the Norwegian registry to have more patients because a general premise behind machine learning models is more data allows more training, more learning for the machine learning models, and therefore should result in a more accurate model. So the hypothesis of this one was that more patients would give us a better ability to predict risk. So we combined the registries and resulted with 63,000 patients this time, same outcome revision surgery as the first paper, again between 1, 2, and 5 years. We trained 4 models, but it ended up being almost identical, so very similar performance as the model that was developed just using the Norwegian registry. And this suggested that we may have reached somewhat of a ceiling of the registries in that adding more of the patients but not changing the variables being collected, so collecting more of the same data, would be unlikely to drastically improve our prediction accuracy. And so this suggested that improving our ability to predict requires an evolution of the registry to be able to collect additional variables that are not currently collected that we believe are associated with risk. And some examples here, radiographic factors, so alignment, tibial slope, additional procedures being performed, clinical examination details, rehab details, et cetera. But this is a bit of a catch-22 because simply adding more variables is actually not so simple. The more variables we want to add, the lower the compliance because you're asking surgeons to fill out more paperwork. And so this requires careful consideration of the additional variables as we try to sort out which ones we can add feasibly without losing compliance. That was the development models, the first 3 papers, and the next 2 papers took the first model, the revision prediction model, and externally validated it using the Danish registry and a group of patients from North America and Europe in the stability trial. So model external validation is a crucial step prior to clinical translation and clinical application of these models because you want to see that it holds up on a different set of patients than you initially developed it for. Specifically, you want to see if it's going to hold up with a different patient set that would eventually be, the model would be used on. Although it is crucial, it is not commonly performed. Studies will oftentimes stall out after it's been developed because there are a lot of barriers to effective external validation, including being able to have the available data, matching data sets, the cost associated, data protection laws, and collaboration. So that 4th paper, we applied the Cox-Lasso model from the first paper, the revision prediction model. We chose the Cox-Lasso model because it was the best performing model, and we applied it to the Danish registry. There were 11,000 patients who had all 5 of those variables that were required for outcome prediction. And overall, the model performed almost identically at 2 years, and overall very similarly to the Norwegian model initially developed, which suggested validity outside of the initial patient population. And this is despite the fact that the trends and surgical practices were different between Norway and Denmark. One example just being much more frequent use of hamstring tendon in Denmark versus patellar tendon graft here in Norway. The 5th paper was very similar to the 4th paper in terms of external validation methods. And this time we used patients from 7 centers in Canada and 2 from Europe, 1 in Belgium, 1 in the United Kingdom. And these patients came from the Stability 1 randomized control trial. Same revision prediction model was being evaluated. The Stability 1 randomized control trial is, again, that multi-center study evaluating the use of a novel technique called the lateral extra-articular tenodesis, LET for short, which is an adjunctive procedure performed on the outer aspect or the lateral aspect of the knee to potentially decrease failure rates of ACL reconstruction. So all patients in this study received a hamstring tendon autograft, and they were randomized to either have an LET or receive the LET or not. So we coded the LET 3 different ways to see how it affected the results of the model. And the reason we did this is because the study actually showed that the failure rate was lower if you added an LET to a hamstring tendon. And we also know from the registries overall that the failure rate is lower for patellar tendon than it is for an isolated hamstring tendon. So by coding it 3 ways, we took these patients who received the hamstring alone, and we coded them in the model as just hamstring. The patients who were randomized to receive the LET in addition to the hamstring, we said, well, how does the model perform when we keep them as hamstring? And then because the failure rates are lower, closer to a BTB, we'll see how it performs if we code them as that patellar tendon. And then for completeness sake, we also check to see how it performed if we coded them as the third graft category for the model, which was unknown and other. 591 patients were in the stability study and had all 5 variables. And there was similar accuracy. And actually, if you look at the concordance, the initial model had a 0.69, 0.68. This one seems higher, 0.71, 0.71. So that would suggest that the model actually did better with the stability patients than the initial development. But the biggest thing is there's a wide confidence interval. So from 0.63 to 0.79 suggests the true accuracy of the model is a little unclear. And that's largely driven by the fact that there were only 591 patients, which leads to a wider confidence interval and more uncertainty. There are 3 main branches to machine learning. So there's supervised learning, which is everything that we've heard about so far. Supervised learning essentially means we give the model all of the variables and we tell the model, these are the predictors, this is the outcome you're trying to predict. Unsupervised learning was the 6th paper in the thesis, and in this case, the model is completely blind to the outcome. You give the model all of the predictor variables and you basically task it to find its own structure and patterns in the data and come up with clusters. So it's a clustering assessment. You can then apply the clusters. You can look at within each cluster and see what the revision rate and to see if there's a difference between them. So we did just that. We applied unsupervised machine learning to the combined Danish and Norwegian registers to identify distinct clusters of patients with similar characteristics. And we thought that maybe this would allow identification of certain groups of patients that would have a unique or different revision rate, enabling a risk stratification more at a group level rather than individual. This is the sort of outcome that you receive, and continuous and categorical variables, and you get lots of information with an unsupervised learning. It doesn't tell you how it groups patients, it just kind of shows you the number of patients with each category in the different clusters. So we found that 5 clusters was optimal, so 1, 2, 3, 4, 5. You can see the different rates, for example, of graft choice between them and the other variables. To help to actually make sense of this, you can apply something called SHAP analysis, which enables us to see really kind of behind the curtain, so to speak, what factors was the model considering when it grouped patients? And so this helps with the explainability of the model. We actually look at the 5 different clusters. The hypothesis, again, was that this would identify maybe clusters that had a higher failure rate or a lower failure rate. And sure enough, we found that clusters 1 down here had a much lower survival than cluster 5. And so all the way down as you go, you see difference in failure rate amongst the 5 different groups. Putting it all together between the SHAP analysis and the different clusters, we're able to simplify it down to 3 factors: graft choice, KOOS scores, and age. And so if patients in cluster 1 had a revision rate around 10%, whereas clusters 5, 4, and 3 were between 3 and 5%. So we kind of classified clusters 3, 4, and 5 as that low risk patient. Cluster 2 is in between at 7%, and those cluster 1 patients had the highest risk at 10%. This, when you follow that algorithm, does enable that rapid risk estimation, so you can place patients based on those 3 variables quickly in a clinical scenario into one of those 3 categories. Putting it all together from the different papers, we did develop the first machine learning-driven ACL reconstruction outcome prediction tools, which can predict revision surgery and inferior patient-reported outcome measures with reasonable accuracy. And it did show promise outside of Norway and Scandinavia through the stability external validation, but more work is needed to check with larger patient sets. The key, though, looking back on all the work that's been done over the last 5 years on this, is that what does it all mean? It's unclear. We don't actually know what the real clinical value of this is, because we don't actually know how the model compares to our own ability to sit in the clinic and estimate a patient's risk. We're pretty good at this point of saying to this patient in front of us, you're higher risk, you're lower risk. But we haven't really been able to really establish who's better, us or the model. There's also an apparent prediction ceiling effect of the registry, as mentioned. So this requires that registry evolution, the addition of more and different variables to the registry. And then the unsupervised learning provided a unique perspective on the interaction of variables and allows clustering. The biggest things for the future are to really leverage AI as we seek to evolve in the registry and collect more of those variables that we think are associated with outcome so that we can perhaps surpass that ceiling effect. We also need to look and see all the data that was used to create these models ended in 2018, 2020. So if we want to know how it's actually doing prospectively, we need to look at how the model performs on the last 5 years. And so work has begun on that as well. And then the last part is my big next undertaking is this tarot study. Tarot as in tarot cards, predicting the future. Testing ACL reconstruction outcome predictions. The last T is from predictions. It's stretched, but it's in the middle. So we want to actually ask surgeons, to the patients they have in their office in front of them, what do you think this patient's risk of a poor outcome is? What do you think their risk of revision surgery is? What do you think their risk of a contralateral knee injury is? Their risk of being satisfied with the results of surgery, returning to function in sport? And run their predictions basically alongside the model who's going to make the same predictions. Other prediction models have since been developed that we can compare as well, and then really see who's better, surgeons, the machines, some combination of the both, and really kind of look to see what the clinical relevance of these studies are. The reality is that we developed this pyramid of how we should think about these prediction models. The developing's at the bottom, and this is done a lot. A lot of models are developed out there, but most stall out either here or here, and very, very few actually go on to compare with human prediction accuracy. And therefore, the clinical relevance of these models remains unknown until we get to here. I would say that the order in which this is done is less important than being able to check all these boxes. So you can certainly develop a model and show superiority over humans. It still doesn't make it useful unless you've done that external validation at all. That's my summary. Turn it over to my opponents. Thank you.
Thank you so much, Kyle, and thank you for the invitation to be here to discuss this with you. Let me see if I can get this working. You made a beautiful thesis, a very good thesis, I believe. And what I'm aiming here today isn't to question it in that way that I think it's flawed. I think it's sound, and what I'm hoping to do is more to engage in a dialogue, and maybe, hopefully, you'll enlighten me on some of my questions, and maybe the other way around, to discuss some of the areas which I think might be further developed. I'm from Denmark's most beautiful hospital in Copenhagen, Bispebjerg Hospital, where I'm professor at the sports surgery department. And I'm happy to come here. We went around the lake just in the break and see the beautiful Norwegian nature. Your aim was to apply machine learning to the Norwegian and Danish ligament register to create and validate machine learning algorithms capable of predicting outcome following ACLR, with particular emphasis on ease of use and clinical applicability. You did that. Now I'll dig into some basic methodological concepts, and then we'll get back to the thesis afterwards. You published 6 papers in 6 well-recognized journals. It's what you can wish for as a PhD student. It's a major task. And then to the methodological concepts. So first, very simple, what is this, Kyle?
This would be the evidence pyramid that we use for evidence-based medicine.
Yep. And can you say, is some evidence better than other, or is all evidence relevant?
Yeah, so the further up you go from the bottom, the higher the level of evidence. So we say that the systematic reviews and meta-analyses are at the top. There's some nuance there in terms of the level of the quality of the studies that are used in the systematic reviews. But other than that, the randomized controlled trials would have higher evidence in cohort, case control, than case series in general.
Yes. And why is that?
So the case series reports, the case control studies at the bottom are either non-interventional studies where you can't truly see a difference between interventions or groups, or smaller groups of patients where you are reporting on observations amongst either single center, single institution, smaller groups of patients. Just overall, the higher you go up the ladder, for example, randomized controlled trials, you're really nailing down specific hypotheses and questions that you can test and not necessarily prove, but at least get closer to what we consider to be the truth.
So I put in the words causality and association. How would you use those in the pyramid if you were to?
Yeah, so association might be factors that are related to one another, but association does not infer causality. So causality would mean more something like if you return to football, you are going to have an ACL reconstruction failure. That's more an association. You see a higher rate in those patients. Whereas if you say that you are under-rehabilitated prior to your return, that would suggest more causality in terms of why that injury might happen.
And where are we with this prediction modeling? Can we claim causality in what you're doing, or so where in the pyramid would your studies be?
So the models are based on registry data, which is around that cohort studies, that mid-pyramid level. And the prediction models are evaluating associations, not causality. So I'd say we're middle of the pyramid and more in the association category as opposed to the causality.
I'm happy I got that right. So we're in the middle of the pyramid trying to predict association, but we cannot claim causality. Yeah, I would agree on that. Then we have this about confounding, that you have causal associations and you have confounding associations. And I found this on the net. I think I like it. So sleeping with shoes on causes headache. Is that correct?
I don't know what kind of shoes that man was wearing, but usually no.
And why is that? Because every time he does it, he wakes up with a headache.
Yeah, so I'm going to go on a limb and say maybe he went to bed after having a few too many drinks the night before.
Yeah, so there's a confounding association here. So drinking makes him go to bed with his shoes on and gives him headache the next day. How could you, when you look at these associations, which is the main part of your study, how would you say, how does confounding affect your associations and your prediction modeling?
One of the strengths of machine learning analysis is that you can account for confounding in the model if the confounders are included as variables. If you don't have the confounding variables available, then you can still be prone to missing out on the actual root cause. An example within the ACL literature would be some of the work done here at NIH to suggest that many studies show that age is a risk factor for failure. Younger patients have a higher rate of failure from ACL reconstruction. Oh, okay. But when we actually dive into it, you can actually see that when you look at rehabilitation status prior to return to sport, you can actually see that some of the age factors go away. And so younger patients may be more likely to return to a high-level pivoting sport and be under-rehabilitated, and therefore that's why you see it.
So age might be a confounder for another causal claim here. Can you mention other things? There's pivoting sports. What could age otherwise affect?
So skeletal maturity, growth remaining, surgical technique, graft choice. Sometimes the surgeons might make decisions on what treatment they're going to use based on factors like patient age, and they might change their technique, which could actually lower failure rate, for example. They might be more prone to use a graft with a lower failure rate than an older patient with a graft with a higher failure rate. So there's many different interactions at different levels, either towards failure or towards lower rates of failure that could be contributing.
Yeah. What about neuromuscular control? How would that fit into this?
So I think the rehabilitation, access to physical therapy, physiotherapy, proper rehabilitation, maybe, again, if they're not finished growing, you could potentially have more physiological changes or adaptations.
Yeah, I'm heading in the direction, it's completely right.
Yeah.
But I was thinking about maybe some of us are just not made to do cutting sports. Maybe we have a neuromuscular activation pattern that will lead to an ACL tear. And when you increase your sport, you might get it. How would you account for that in a modeling like this?
So factoring in, I guess what you're getting at there would be age. Kids are generally more active than certainly we are as we get older, so they're involved in more sports, maybe those who aren't necessarily as
the
athletic.
amount of hours, maybe you will get your ACL after 100 hours of playing handball. Due to
Yeah.
Just that it's on your path.
Absolutely.
Yeah. Then we have bias. What's the difference between confounding and bias?
So confounding, as we've discussed so far, is essentially one factor essentially representing another factor that is actually more the driver of that, again, that causality or what's happening or that association, but you don't recognize it because either you're not directly measuring it or you miss it somehow. Whereas bias is, there's many different ways you can have bias. It's inherent in the way you're measuring or reporting. You can, yes, multiple different types of bias there in terms of, when you develop the model, there's inherent biases in the data that you're using, where it's coming from, and many of them are listed there that I would say can be prevalent with prediction modeling.
And looking at the registries, can you mention some biases that might be inherent in the way we gather these data?
So the registry is great because it collects everyone in the country who has an ACL reconstruction, but not quite, because there's still some patients that don't make it in. The completion rate is somewhere between 85 to 95%, but that still means that 5 to 15% of the patients in the country who have an ACL reconstruction are not captured by the registry. Or those 5 to 15% of the patients who have a subsequent failure would not be caught. And so if there's an inherent difference between those patients who are in the registry and those who are not, then it's biased towards patients who are in the model. Similarly, if surgeons from certain regions are more likely to enroll their patients and other regions are less likely, there might be bias in terms of that patient selection. But there's definitely layers to the bias that can occur. Again, whether that's socioeconomic, gender, racial, temporal, so changes. The registry started in 2004, and our models included patients from 20 years ago. Mm-hmm. And thankfully, our techniques and implants have changed and evolved over the last 20 years. And so there's always that temporal fact that patients in 2005, 2006 may just have a different outcome than patients in 2016 or in 2025. And so there's bias towards the patients that were used to develop the model might be different than what we're applying to right now.
Mm-hmm. Very good, thank you. Then we're jumping quickly through those basic concepts here. Do you know about the COSMIN, what that is?
Yes, so that's an international collaboration to essentially determine the suitability of outcome measures for various conditions that are best suited to tracking outcomes for that one pathology.
Yeah, and have you heard about these overall principles within outcome measures?
Yes, so the reliability would be, does it hold up? So if you measure the same person a few different ways or different times, you get consistent results. Mm-hmm. Whereas the validity is more so, is the measure truly testing what it purports to test?
Mm-hmm. And responsiveness?
Responsiveness is it susceptible, I think, to changes, I believe. Mm-hmm. So if a situation changes, does it pick up on those changes?
Yeah, does the measurement actually pick up a change in the condition of the patient? And that leads to the outcome you chose. So if we start by revision following ACLR, and you try to apply this COSMIN model on it, can you discuss, is it a good, is it a less good outcome measure to use?
Yeah, this is a major point in the ACL literature, I would say. ACL outcomes in general, you can group into early adverse events, graft failure or ligament disruption, clinical patient-reported outcomes, and then clinical measures of knee function or structure. And so clearly we're talking about the graft function and ligament integrity with this. And there's really no agreement in terms of how best to measure that, because you might have patients who fail but don't go on to have a revision surgery. So you're missing out on those patients if you're just measuring revision. On the other hand, being able to quantify degree of laxity and truly capture those patients who have failed or re-ruptured, it's more challenging. So I would say that capturing patients from the registry who have had a revision is certainly the most objective way of capturing failure. No one will argue with the fact that if you've had it redone, it must have failed. But it misses out on maybe those patients who have had it fail and didn't have that revision. So therefore, I'd say, between reliability and validity, it certainly is capturing what we're purporting to capture with the validity. And the reliability, I guess, is more of that measurement error bubble that you might miss a few.
And what about responsiveness? Is it because I think it's rather reliable that if you've got a revision, you've got a revision. It's probably difficult to discuss that. But if you want to go back to high-level soccer, for instance, how many would you estimate would be able to do that after an ACL reconstruction on the same level as beforehand?
Yeah. So I know that the return to sport rates are fairly high, but it's still probably around that 70 to 85% range, depending on the sport. And even lower would be at the same level or higher than it was before.
So I think they say something like plus 90% go back to sport if they're elite athletes because they're paid to do it, but they fail, and maybe if around 50% do as good as they did before for a longer period of time. So there's a long way from 50% success rate till 5% failure rate. So I'm wondering, could we think of another way to measure success or failure, which could be applied in the registries? So this is a hard endpoint. It's good in that way, but you lose a lot of sensitivity, I would argue.
Yeah, and I think this is where the Panther guidelines or symposia have suggested that when you're tracking these outcomes, you should track patient-reported outcome measure. The IKDC was kind of recommended because it actually tests on instability. So asking patients, do you have instability in your daily life and with your activities? Some sort of return to sport question, I think, would be a valuable add. There's no agreement on how to ask that question, because the other thing is that many patients don't want to return to sport after ACL surgery. Maybe they're at a different point in their lives, they've moved on, they're not going to return to those sports. So more so getting into their functional assessment is important. The PASS, patient acceptable symptom state, is an important measure to basically ask patients, are you satisfied with your functioning after your surgery? So you kind of need a multi-pronged approach to truly capture failure. You can't nail it down to just one factor.
So you're arguing some kind of a composite score to catch it.
Yeah, SANE score would be another one potentially, but again, it's one of many.
And it leads to the next outcome in the next prediction model, which is the KOOS quality of life. And I know you didn't choose it. It was chosen for you 20 years ago. So you can feel free to debate it and discuss upon it. Do you think this is a patient-reported outcome measure? And again, if we apply the Cosmin model on it, is it a good outcome for measuring result after ACL reconstruction?
The short answer is no, not for these patients. So the KOOS is an adaptation of the WOMAC, which is more of a longitudinal assessment of how a patient progresses from their injury through till arthritis. It's a good measure for arthritis and knee function. But the KOOS, the quality of life, if we're just talking about that subscale, I would say that you can make a strong argument that if you score below 44, you're not doing well. So from that standpoint, again, it's more of that, it's not objective, it's subjective, but it is a marker of someone who's not doing well. But it's not really going to capture those patients who have failed as well as we would like. There are no questions about instability. There are no questions about return to sport. And realistically, a lot of these patients with these measures, there's a ceiling effect where it's hard to kind of get that responsiveness because a lot of the questions that ask on the KOOS are too easy for the patient because it's more of that longitudinal arthritis assessment.
Yes, very good argumentation, thank you. So it's difficult to measure well-doing patients, but those who fail, you will probably catch with a CUES quality of life below 44.
Yeah, and I think that there's been validity in the sense that a high proportion of patients who score below 44 end up having a revision. So it does capture those ones that maybe haven't had that revision yet. But still, it's not going to be 100%.
Then you write you use the tripod guideline. And since I'm not doing prediction studies myself, I didn't know this guideline beforehand. Why is it important to use one of these guidelines?
Guidelines like this exist for most of the different types of research on that pyramid, and they can really be used, and they're important to use, to standardize the way we report. So we're all speaking the same language when we are performing studies, reporting outcomes of studies, and really putting them into clinical context and clinical care. So it's kind of a baseline or a standard level that we should follow when we are reporting our studies and performing the studies to make sure we do them rigorously and appropriately. And I admit I didn't know about them either when we did our first study. I found out about them after we'd already submitted to the journal. So the first study we did, although we followed, I'd say, the majority of the guidelines just because that's how we built our study, we didn't have the full checklist. We did for the rest of our studies.
Did it bring a lot then? Did it add positively to the following studies? Or was it more, did it matter?
No, I think it did. So we changed a few things after looking at the tripod guidelines. Number one was reporting the confidence intervals. So when we looked at our first paper, we reported the concordance, but the discrimination ability of the model, but we didn't actually include the confidence intervals. And so that was something that we looked at and said, oh shoot, we missed that. We'll include that in our future papers. The other thing was it kind of just reaffirmed our approach. So we wanted to do this from a rigorous standpoint that would hold up long term. And so we looked at and went through every kind of point and said, what do we need to change? And the important one for me as a clinician, not as a biostatistician or someone doing the analysis myself, was are we doing the right models and are we reporting the model performance the right way? And that's where, there are so many different measures to report on, but this also kind of confirmed that calibration and discrimination would be the two most important, and then all the other measures can be added, but those are the two most important to report. And we continued with the rest of our papers to focus on those two measures.
Thank you. Then we have this guy. Do you know who that is?
I don't.
It's a mean question, I know. Does anybody in the audience know who it is? Well, you're helped by that then. Yeah. It's the father of evidence-based medicine.
I should know that.
And can you say something? What is evidence-based medicine?
So evidence-based medicine, actually probably say kind of originated in Canada, but it is guiding clinical practice based on largely that pyramid, proper research and instituting changes to clinical practice based on best available evidence and scientific critique and review of these articles to just overall bring up the quality of care based on the best available evidence we have available to us.
Mm-hmm. So we have the patient values, we have the clinical expertise, and we have the best scientific evidence that overlaps into this little triangle in the middle. And I don't have an answer to this question. I hope you can help me. But how does AI fit into this? Does AI account for all three aspects, or is AI more focused on best scientific evidence?
I haven't thought of it in that context, but I just looking at it right now, I think it probably touches on all three. I think the biggest thing for my view of how AI can help us is really just another tool, another source of information to guide our clinical decision making, so guiding that evidence. And so that clinical experience, I think, can benefit from some of the AI innovations and predictive modeling to give us more of that information to guide our discussions and decisions. But we have to keep it in mind with the patient values. So we talk about the different outcomes, right? The outcome prediction or goals for the patient might be very different for that 21-year-old professional football player versus that 36-year-old accountant who weekend warrior playing pickleball tore their ACL, right? So what's important to each of them might be very different. And so AI integration could potentially elucidate some of those differences and guide more of that patient-specific care down the road. Best scientific evidence, I think, again, it's just more information from the literature and the best available variables and evidence we have out there, and AI can help stratify that and tease out the important factors for our patients. So it probably does relate to all three.
Mm-hmm. Yeah. I can't get my head around it. Like, in the Lancet they published, was it last year, that now AI is more empathetic than we are. They understand the patients better. Some doctors are arguing that the medical practitioners will be without job within 5 to 10 years because AI is more accurate, more empathic, and so. Yeah. I don't know if it encompasses all three or if it's mainly best scientific evidence and maybe some clinical experience as well.
I think anything that a human can do, you can train a model to do if you have the proper ability to train it. And so that should be seen as a good thing. It can help us do our jobs better, and I think help us focus on the patient in front of us and not have to worry as much about the noise. It can make us more efficient. It can further our ability to treat our patients the way we want. So I think overall it's a value add, if done the right way.
Mm-hmm. So it's just a question leading, but how do you imagine a consultation in 5 years then? Yeah. The patient enters your clinic, and what then?
I think clinic flow is very different wherever you are. One of the big changes I think we'll see is a lot more information at our fingertips, and maybe kind of even before the patient arrives, maybe they have received their little survey on their phone they filled out, so we already have a lot of information about them to begin with. Maybe the imaging that they get in the clinic or before the appointment is already automatically read, much like an EKG, right? EKGs used to be read manually for every single one. Now it kind of comes out with a preliminary read right away. It's still reviewed by a physician for accuracy and to look at it, but we kind of get that information in a standardized manner right away. And that allows us to kind of frame that background information. I still think a discussion with a patient, there are going to be probing questions you still need to ask, but it really allows you to focus on the patient's goals. You tease out where they're at, where they want to get to, and sort out together through that shared patient, surgeon or physician decision-making, the best path forward. So I don't think we're going to be replaced anytime soon. I think some subspecialties within medicine are more apt to be relegated to the sidelines of more overseen models doing things like radiology, for example, checking what the automatic read was. But I remain cautiously optimistic about our profession as orthopedic surgeons that we will continue to have jobs for the foreseeable future.
I imagine so as well. Since we had the pictures, do you know those two, and utilitarianism and deontology?
Yes, I'm going to stay in my lane though and not purport to know very much.
And it's again placing AI in this spectrum from, in utilitarianism, you have a perspective that dictates the most appropriate action is the one that achieves the greatest goods for the greatest number. Whereas in deontology, it's about the person. It's about bringing the best for the individual person. Can AI span this, or is it more in the utilitaristic direction?
I think you can fine-tune it. The corollary for this is kind of that sensitivity, specificity in medicine, right? Would you rather a high false positive or a high false negative test? And it kind of depends on what you're checking for, right? If you're looking for potential cancers, then it's better to have a very sensitive test that's going to pick up on even just a minuscule risk, and then you can over-test patients that maybe don't have it to be able to capture the ones who do. So you can kind of fine-tune any test we do in medicine based on those parameters to maybe initially develop a model that is more of a one-size-fit-all for all comers, greater good, works for most people but not necessarily everyone. But I think that we're going to see in the future more of a local fine-tuning of these models for that patient from either geographic, even surgeon level, institution level, health region level, geographic area. What's going to be important is really just, does the methodology work in general? And then each place will use their own data to fine-tune and develop a model that will hopefully deal with, I'd say both, help everyone from a global health, public health standpoint, but then allow that individual best care, which the deontology is focused on.
So
I know that guy.
Then getting to the thesis.
Thank you for that.
So load the shotgun. We are getting into the papers. So it's I asked AI on the left. It's a bit more smooth, can you see, than at the right, where I tried to figure it out myself. How does AI and orthopedic surgery merge? Your aim of the thesis was to apply machine learning to the registries and develop these algorithms. And you made a range of specific goals. I'll go into the first 3 papers, and then I'll lead the more heavy stuff to Jacobian later on. So you wanted to identify the most important risk factors associated with subsequent revision following primary ACLR using supervised machine learning analysis of the National Norwegian Knee Ligament Registry. And a first question here could be, does the Norwegian Knee Ligament Registry contain the most important risk factors associated with subsequent revision?
Great question. No, it does not. It contains several of the factors we have identified that we think are highly related to or important, but it definitely misses some that we have also identified through other studies. And I touched on some of those earlier, things like tibial slope, rehabilitation. Those factors are not in the registry itself.
Mm-hmm. Then make clinically useful prediction models, and you touched upon that in your presentation before. Did you get to that, you think?
Clinically useful remains unclear, but clinically useful in the context of, could a clinician use this in a facile manner in the clinic? Absolutely. 5 factors, pretty easy to click in. The true clinical relevance is the part that remains unknown.
Mm-hmm. And does it give me something I didn't know ahead?
I think it does, in the sense that when we started this whole thing was, again, that patient comes into my office and says, hey, like, what are the chances I'm going to be back here again in a few years and fail? Mm-hmm. And so the approach without a model like this, you kind of say, well, 5% failure rate overall in the registry, at 5 years, it's usually this percentage. But how does that relate to the person in front of you? We kind of say, well, you're young and you want to get back to pivoting sport, you're probably higher risk. But to actually quantify this and really guide a patient and say, you have a very low relative to the average. Here's your average risk prediction. Especially a calibrated model, you can kind of say, if that model says you have an 18% risk of failure, you can say that of 100 patients just like you, about 18 of you would be expected to have a revision within two years, or whatever time frame you're choosing. So it can guide those discussions, and you can also play around with it and kind of see, not that I recommend use of this, but maybe in the future we'll get there. You can see how those risk scores change based on different inputs. And especially if graft, for example, is one of the variables, you can say, look, you're in that failure rate of 18% if we use a hamstring, but it drops to 6% if we use a BTB. That might guide that management decision. Whereas if you have maybe an older patient or other factors and the difference in the graft choices is maybe 2%, maybe they choose a different graft. So I think we're still teasing out the true clinical utility, but I think that accurately being able to predict outcome as a general principle is incredibly valuable, especially if you can kind of play around with it to see how those risk scores change.
We'll get back to that later on. Just a side question, because for the population, I might have an 18% risk of a re-rupture or a failure. But for me as a person, it's either 0 or 100.
Right.
So how do you connect those two when you have a patient in front of you?
That's where I think you have to recognize, as long as it's a calibrated model, you can kind of say, of 100 patients like you, 18 would be expected to have a failure. And that's, these models are not dichotomous. This is not a binary outcome. We're not telling patients, you're going to fail and you're not. Because then you have to set a threshold. You have to kind of say, all right, a score above this, you're in that category of failure, and below this, you're in a category of not. But that would suggest a big difference. If you got a cutoff at 18%, and you come in at 18%, and we say you're going to fail, and someone else comes in and they have a risk of 17%, and you say you're not going to fail, the true difference in risk is very small there. And that's why these models are about kind of continuous variable outcome, where you kind of say you're on a risk prediction score as opposed to a fail or not output.
And how much does it matter? You know, if it's a med student, 18% risk failure is a lot. If you're a professional athlete, it doesn't matter because there's only one way to go. So how does it matter?
So a few other areas that could help would be, well, I think the expectation setting is kind of what we've talked about so far, so the patient kind of goes in knowing. But the other part is that by accurately predicting someone's risk, you can maybe do some further studies, take it to that next level, where maybe you can take those patients who are in that low risk category, those 4%, 6% patients, and maybe you can do an accelerated rehab program. Maybe you can get them back to sports sooner, whereas maybe the higher risk patients, you hold them back a little bit longer, you focus more on other factors, or change your surgical technique and add things like LETs or other procedures to bring that risk down. You're right, it's not going to change the decision of whether they're going to have surgery or not necessarily, but it might change the surgery approach. It might even push you over the edge for something even big that might be crazy right now. Tibial slope correction, right? Osteotomy in a primary surgery is not really done right now. But if we can accurately identify patients who are higher risk for a model like this, maybe we start thinking about those interventions earlier.
Mm-hmm. Very good answers. Yeah, it's the same to the next questions here. And then at the end, you wanted to improve the accuracy of the revision prediction model through amalgamation of the Danish and the Norwegian registries, which we'll get back to. You didn't succeed on.
Correct.
Good. The first paper, Predicting Anterior Cruciate Ligament Reconstruction Revision, a machine learning analysis utilizing the Norwegian knee ligament register. And you say here, machine learning predictive models have the ability to consider all patient injury and surgical factors while generating not only a patient-specific likelihood of poor outcome, but also the magnitude of effect of each variable. Sounds great. Whereas this contrasts to non-machine learning analysis, whose validity relies on researchers' underlying assumptions to correctly specify which variables to include, how they interact, and their functional relationship to the outcome. Please explain this to me. Why?
Yeah. So, admittedly, if I were to go back, I'd probably change that first sentence, because the reality here is that a machine learning model is only as good as the data used to build it. And the registry has been pre-specified which variables are being collected by a human, and it does not have access to all patient injury and surgical factors because it's missing some of the factors I mentioned earlier. So in that sense, I guess it is a little bit off the mark, but what I really mean there is that you don't have to pre-specify and say, you know, these are the factors that are important and we think that this is the relationship, and then you test that statistically. That's the traditional approach. In machine learning, you basically can give the variables. You try to focus on the ones that you think are important and not include the ones that aren't important. But even if the ones that aren't important are in there, the model evaluates the different interactions and complex nature of the relationship between those predictor factors and the eventual outcome. And it can oftentimes tease out some of those relationships, particularly when there is a complex interaction, better than traditional statistics can. Now that said, if you have more of a straightforward problem or interactions, or if you have a thorough understanding already, then traditional statistical analysis can oftentimes suffice.
Mm-hmm. So if you do a generalized linear model, you will somehow rank your outcome or your variables, whereas here you don't have to do that. You just put it in and it does it for you.
Yeah, the feature selection allows you to essentially test the model, see how it does, and then you can eliminate factors as you go. And as long as the outcome or the prediction performance doesn't change, then those ones aren't included in the model. So you can really pare down the data set from 24 variables down to 5. And you get to the point where eliminating further variables might make it easier to use clinically because you have fewer variables, but your performance might drop. Whereas you get to the point also where keeping additional variables doesn't appreciably improve the performance. Mm-hmm. You find that sweet spot.
Because you put in a lot of variables. And doing that, I would think you have a risk of multiple testing, that you have a risk of finding something which might not be significant. How do you control for that in a machine learning model? So it does it itself, or?
Yeah. Thankfully, I have a great team at the University of Minnesota who did a lot of the fine-tuning the parameters for me. So I don't do this part myself, but my understanding of it, and based on my discussions, is that the part of it comes down to, again, that feature selection, the model being able to remove variables and see how the model performs, different validation techniques, and getting into the data, basically tuning it using that testing set, not the training set, not the testing set, and using that holdout test set to really test the performance of it. You'll find out when you test it on the new data whether it's accurate or not.
You can tell me anything because I don't understand it.
And I'll stop there.
So as an orthopedic surgeon, I'd say I'm a rather simple guy in many ways, and I like to be able to understand what happens. And this is a black box. You put in some data and you get out some data, and something happened on the way, and it kind of scares me a little bit. But we have to believe in those who are cleverer than we are ourselves. But it's about this, as you said, garbage in, garbage out. You chose 5 variables, found 5 variables being important. Patient age, we knew that already from Kate Webster and Julian studies. Preoperative coups leads to a postoperative bad result, bad coups, makes sense. Graft choice, we knew that ahead as well. Femur fixation methods, time between injury and primary ACLR. And then you made some modeling. I took this from the thesis. Can you explain to me what we see here?
Yeah, so the orange bars are, is this still on? So the orange bars here are the factors that were used in the Cox-Lasso model and the generalized additive model. And you can see that the random forest and the gradient boosted had more variables. Some of them are orange because they were from up here, and some of them aren't. And again, this is association, not causality. And the effect size, this does suggest that the different graphs have more of an input in terms of how the model predicts risk. But again, using that feature selection, all of them were important. And if we were to remove even just one of these other factors, model performance drops. Mm-hmm. And if we were to add other ones that maybe aren't on here, it didn't appreciably improve.
So is it correctly understood that a large bar means that it has a large influence?
Correct.
So in the Cox-Lasso and the generalized additive model, it's graft. It's choice of graft that really matters.
Largely graft-driven, again, largely graft-driven, but again, it's not causation, it's just the association that the model put a lot more weight on the graft choice because that was a factor that was more associated with outcome relative to the other factors, which were still important.
And if you take the 2 lower models, it's age that matters.
Yes, it was age that matters, and also these ones required more variables. So again, if we talk about that clinical utility, we would need to input all of these factors to be able to use a gradient-boosted regression model.
So based on these considerations, you chose to go for the Cox-Lasso model.
The performance measures between all 4 models were very similar, but because this one was clinically the easiest to use, we went with that one.
Yeah.
I should also mention that Cox-Lasso is kind of the most basic penalized regression model. So when you talk about machine learning approaches, the Cox-Lasso is closest to more traditional statistical techniques. And these ones are, again, more ensemble and boosted models that are a little bit more involved.
So then being a little rude, so in contrast to machine learning analysis, then when you do not do machine learning analysis, it relies on the researchers' underlying assumptions and what they choose. But here you chose. You could have chosen the other model, and then it would have been the other way around. So leading to, do you know this guy? Jean-Paul Sartre.
The context is eluding me, but I know the name.
Yeah, he's an existentialist saying that the choice is always yours. Because depending on whom you ask, you get a choice of your wish. And isn't it a bit like that? So you could have chosen the other model, and then you had gotten. So what does it bring that a simple regression analysis would not bring? Because you ended up choosing the model that you thought fitted the best.
So had the outcome in terms of model performance been different, we would have chosen differently. So this is the advantage, is having different techniques. You can actually see different data sets. And one of the papers that we had, the third one, the Cox-Lasso model performed most poorly. So then we chose the more complex model. So the human selection is basically just choosing whichever model performed the best. And in the case where they performed similarly, chose the simplest model. That's the statement, the quote from the paper there, I would say is more of a statement on machine learning approaches in general relative to traditional statistics and not specific to this analysis.
And you got this beautiful model where you can see the mean, and then you can change the different parameters. And if you go for a lower age, you have a higher revision rate. And if you go for a hamstring graft, you get a higher revision rate. If I have those two parameters and I put them in, does the rest really matter?
You can see differences if you play around with it in terms of the risk scores. And it comes down to, keep in mind that the output isn't perfect. What we're really looking for is the combination of all 5 give you more confidence in the model, because that's where you achieve your best performance. You could have a model based on those 2 risk factors, and it would probably be reasonable, but it wouldn't achieve the same level of performance as having all 5.
As the simple guy I am, being an orthopedic surgeon, I could say you're young, you have a higher risk, which I knew before. If I give you a BPTB, you have a lower risk, and that's about it. Is that unfair? Or?
No, that's totally fair. It's the ability to quantify, or not quantify, sorry, but estimate that risk that I think becomes more accurate when you have just a few more variables in this case.
So then to some new words for me, concordance. So you found concordance rates around 0.7. So if I understood it correctly, in 70% of the cases, the model predicted what the model prediction was correct. Can you say it like that?
Not quite. So concordance is a modification of the area under the receiver operator characteristic curve, AUC, which is used for censored data. And so it's a discrimination, and what you're basically saying is you grab every pair of patient who has had a revision and who hasn't. And what we're saying is that approximately 70% of the time, it correctly assigned a higher risk score to the patient who had the revision than the patient who didn't. So it's not 70% accurate. It says that your risk score is higher than someone who didn't have a failure if you failed 70% of the time. So it's ability to discriminate between those who are higher risk and lower risk.
Is it good?
Well,
so if it was you, if you were coming in and should be guided by this, would it be sufficient?
The 0.7 or the 0.69, we'll say,
yeah.
We don't know. And so the traditional approach to these sorts of in industry, for example, who use a lot of machine learning, you want to have closer to 0.9, 0.95, 0.99, right? So 1 is the top, the maximum. It's 100% accurate. 0.5 is random chance, so there's no ability to discriminate. And so the closer you get to 1, the better you are. But in clinical care, we have to change the way we look at it a little bit. Although it'd be great to have a model that is 9.93, you'll never really get a model that accurate in something like this because you're looking at revision surgery and all the reasons we discussed earlier, where patients might have a revision, might have a failure but not a revision. You might have patients who left the country. You might have patients who died, so they're not going to be captured before they actually had the outcome. Lots of different things can contribute to it. You can have someone who, they're a low-risk patient, but they're in a car accident, or they slip and fall on the ice and they re-injure their knee. So there's too much random chance associated with it. So what actually constitutes a usable model is oftentimes between 0.7 and 0.85. Because the other part of machine learning analysis you have to be careful with is overfitting. And that means you're overtraining the model based on the data that you have. So you can train and train and train to really get a model that works really well. Look at this, and there's papers out there that say they can predict ACL failure with an AUC of 0.93. But I would argue if you take that model and apply it to any other group of patients, it's not going to perform as well. So that's where I think that the clinical relevance remains unclear until we know how this compares to us. Because if you have a patient in your clinic and you can predict with an AUC of 0.78, then the model doesn't mean anything. But if you're close to random chance, then maybe it's not perfect, but it's clinically useful.
Thank you. And what about AUC?
Yeah, so AUC is used for non-censored data. So you can't use it for the first study, could use it for the second one. And the AUC is basically equivalent to concordance. It's just another measure of discrimination for time-dependent data or when there's no censoring. So a prediction of a binary outcome.
Then another question. So you write here, the 2-year revision predictions demonstrated p-values below 0.5, suggesting statistical difference between predicted and observed outcomes at this time point. And again, being a simple guy. So the model fits at 1 year, fits at 5 years, but does not fit at 2 years. It makes me worried.
It does fit at 2 years. And so that's the other things that we have learned, as I have learned throughout this PhD journey. There are things that I would word differently if I were to go back in time. And the reality here is that, like any statistical test, we're talking about calibration now, so maybe I'll just back up. So the two main measures that we talk about when it comes to assessing the model performance would be discrimination, which we described as, does it properly rank patients in order, right? Do the higher risk patients have the event and the lower risk patients don't when you pair them up? Calibration is how accurate are your predictions. So if you divide them into groups, and if you said in the entire data set, the event occurred 5% of the time, and all of your risk predictions are around 40, 45, and 50%, that's a poorly calibrated model, because it's not actually reflective of the true risk. Whereas a calibrated model, your risk predictions would be closer to the actual event rate. I don't know if I explained that properly, but you're basically looking, this is more a measure of the accuracy of the predictions. Sample size can affect p-values. And so when you have a large data set like a registry, you've got 20,000 patients, then you're going to have a smaller p-value and be more likely to say that this is not calibrated. But that's largely driven by the statistical difference rather than the clinical difference. Because if you actually, and I dug into it after the fact, the C statistic, which is calibration statistics in the middle here, this is a better marker when you have large data sets. And so this Hosmerl, Emshaw assessment of calibration, you divide the group into 5 groups, so quantiles, and then you add up the mean squared error in each group and perform a chi-squared test. So the calibration statistic is the sum of the mean squared error in the 5 groups, and this is the result of the chi-squared test. Higher values suggest miscalibration, lower values are better. A miscalibrated model in data our size would probably be C statistics in the neighborhood of 50, 75, 100. So numbers of less than 12 suggest that the difference between the actual prediction and what actually happened was about 1%. So it was statistically miscalibrated, but if I tell you your risk of 6%, but it's actually 5%, it's not that bad. And so that's where the p-values, because these sample size were so high, technically, statistically, but not clinically miscalibrated would be my argument.
Well, I won't try to argue against that. Yeah, it's about the same. We went around that. Then paper 2. So predicting subjective failure of ACL reconstructions and machine learning analysis of the Norwegian knee ligament register and patient-reported outcomes. So the difference here is that you look at patient-reported outcomes instead of revision surgery. And the main problem here, I think, it's the quality of data in the registries. Can you put some words on that?
So patient-reported outcome measures are important, but we lose out on patients as we follow them over time. So in Norway, high capture rate for patients who have more surgery, so we can capture a lot of patients who fail and have a revision. But the reality is that I want to say it's only 60% compliance when you get a few years out from surgery in terms of the number of patients that actually return the 2-year coup. So you can see the number of patients, almost half the data was lost to follow-up essentially because they didn't complete their 2-year outcomes. So on one hand, we still have over 11,000 patients, which is ample for this sort of analysis. But again, it can touch on that bias that there might be differences between, fundamental differences between the patients who responded and those who didn't that we won't know.
And could you do anything to figure that out, to get closer to whether these are in fact valid data or they are biased data?
Yeah, so we evaluated the missing data using multiple imputation and kind of comparing the two groups to see if they were similar. And based on the variables contained in the registry, they were similar. So we would say that statistically we should be able to infer based on the 11,630 patients that it's representative of the entire group. But again, we don't know that without having the entire data set.
And here you end up having more variables. How do you explain that?
So the prediction of inferior patient-reported outcome, when we did that feature selection, the model performance dropped if we tried to get rid of any of these, and including more variables did not appreciably improve it. So again, this was kind of that sweet spot. And certainly what I found interesting when you look at the list of outcomes is how patient-driven these ones are compared to the predictors we saw from the last one, which we have a lot more control over as surgeons.
And is that surprising when you look at a patient-reported outcome, you think?
No, we know from many different studies that the strongest predictor of how someone's going to do after surgery on a given patient-reported outcome measure, the biggest predictor of that is your preoperative scores. Maybe just be the way people interpret it or the way they answer it, hard to know, but lower scores before typically equate lower scores after.
And then the third paper, that you gain ceiling effect when you compare to when you engage the Danish registry as well. Here you end up having looking at a lot of variables here. Can you add some words to that?
So the combination of the data, data collection is a little different between Denmark and Norway, with a lot higher rate of missing data from the preoperative coup scores, for example, is just one example of missing data. And the standard approach that we used in the previous two papers, the Cox lasso and Cox regression, didn't perform as well in this larger data set. So it required more variables and underperformed compared to the other models. This suggested there was maybe more complex interaction or association between the variables in the two registries combined with the outcome. And so we actually changed one of the machine learning models. I admit I can't remember which one we got rid of, but we applied a super learner for this one. And we did that just because the models seemed to do better with more complex models. So we added a super learner, which uses a bunch of different models and to see if it would perform better. It wasn't the best, but it was just another approach when you look at the data to see which models fit the data best.
And you end up concluding that it didn't bring much to the concordance rate doing this.
No.
Then you mentioned that there are 4 other prediction models out there. Can you put some words on these? I mentioned the author and the variables they looked into.
So these are the other 4. There's a 5th one now as well that have applied machine learning to predict outcome following ACL surgery. And they all report better performance, model performance, than our studies. Again, my concern with these papers is not externally validated, but more importantly, the number sizes were so small. The number of patients, the sample sizes were below 500, 600, 700 patients in each one. And on one hand, you can make the argument that going from 25 to 63,000 patients didn't appreciably improve performance. But I would be really hesitant to make generalized conclusions from a small study like these ones. But this is where I think collaboration and external validation moving forward, which we have planned with our Tarot study, is testing all these models as well, prospectively on different patients, will really tease out how we're doing.
So you built, or you showed this pyramid with the 4 different ways to validate a prediction model, and you are with the Tarot study doing a and the upper one, compare with human prediction accuracy. Are we there yet? So the modeling you have done, is it ready to do that? Or are there so many potential biases, confounders in it, that we might not be above the first step, developing a valid, usable algorithm?
I think it's time, and the reason I do is because we can wait indefinitely, because models are going to come out all the time, and they'll have scores, and they'll be 0.92, 0.65, they'll be all over the place. But the reality is that a prospective external validation compared with surgeons really checks a lot of these boxes at once. And so more important for me, I think, is if we can quantify how well surgeons can do it, that establishes the baseline. And if the current models, whether it's the one we've developed or any of the other ones you've shown there, if any of those outperform the surgeons, that becomes the new baseline, and you don't have to compare with surgeons anymore. So I think that we need to establish how well surgeons can predict outcome before we really just develop more models, I would say. Because if someone goes out there and develops another model, and even if they externally validate it and it does well, we still don't know if it matters until it's compared with humans. So you're right, it might be a situation where we compare with humans, and then 5 years from now we have to do another study comparing a newer model that is better, but at least we have somewhere to start.
Yep. Then this thing about general data extraction, that the data we have now are limited by the registries, and now you are changing the registries to get in more models, but it would be so cool if we could extract data, just have this AI model extract the relevant data. It sounds really intriguing and easy, but how do we do that?
So this is something I'm also working with the Norwegian registry on, and it's going to require time, collaboration, changes to workflows, but I really see this as being the future of the registry, to kind of take it to that Register 2.0, we're calling it, to automate the extraction of as much information as we can to allow the surgeons to focus on the patient and their surgery. You're never going to escape the manual input, but being able to focus the attention on the variables that we can't collect automatically will hopefully serve to decrease surgeon burden while increasing the number of usable variables in the model, or sorry, in the register overall. So I think the large language models, the example I showed earlier this morning, can be used to extract from clinical notes and the patient's chart. Computer vision, I think, is huge for things like tibial slope and coronal alignment and other measurements that you can automatically pick up on. And so we'll kind of see where it gets to, but this is an ongoing project. That's another little vision for me.
And the question, I think, also is it possible to get there? Now, it was Julian Feller's expression here, the loony factor. You know, as a clinician, you have this feeling with the patient, and somehow our brain captures so much, which, I don't know, maybe if an AI model had access to all the social media and work, and so it would be able to capture this, but I guess it's probably not possible. And so will a modeling be able to capture the patient in a way that we can with the human brain?
That's a great question. Part of it comes down to comparison of the model with humans, right? So we have a lot of information available to us, and that's where, you know, asking surgeons to make their predictions and seeing how it performs, we're assuming, my assumption, the underlying hypothesis is that surgeons will outperform the existing models because they have that knowledge. They know the patient's goals, whether they're going to return to sport. I think we have more information that will ever be available to us in data sets. But we might also find that doesn't matter as much as we think it does. Or we might get to a point where, with the collection of all these additional variables we're looking for, we get better but not perfect. And then maybe we get to a point several years in the future where we say there's a patient-reported outcome measure that captures that loony factor maybe a little bit better, and can hit upon the return to sport index or like other mental barriers to return to activity and affecting outcome. So I do think it's possible. I think it probably will need to be a stepwise approach, because the other part is symbiosis, right? So there's how does the model do, how does the surgeon do with all the information available, and then how does the surgeon do when it's combined with the model? How does it do when the surgeon knows what the model's output is in the context of the patient in front of them? And that's, in many cases, better than just the model itself. But surprisingly, even with some really good models and the clinician's experience combining the two, sometimes the model still outperforms that surgeon who has the model and is changing their predictions based on their experience. So there are examples out there in the literature, but time will tell. The jury's still out.
We discussed this in the beginning, so I'll just skip over that. And then getting back to what I think makes your thesis excellent, that you're so humble, and the questions I built up on the way, thinking I have to have your answer on that. You actually do that throughout the thesis, and this statement that over 5 years has passed since the work began, and in this period of time you have learned a lot and things have developed, and being frank about that, the studies might not possess known clinical relevance in themselves. I think it's a very important thing to bring forth. And then summing it up like this, that although the clinical relevance of the thesis remains indeterminate, it's proposed that the 6 studies brings value in themselves. And I completely agree upon this. And it leads me to the entrance of your thesis. She did well. She made you a humble researcher. And I'm not that worried about the AI guy anymore. So time to celebrate. So thank you for a good discussion.
Thank you.
Thank you. So we will have a 15-minute break, meaning that we start, should we say, 10 past half? 10 past half sharp? Okay. Yeah.
Bare skjermøretappen igjen.
En time prating igjen. Ja. Ja.
Test, test. Good. Yeah, sounds good. Dear Cal, so I have the honor to end for the last questions for you for your PhD defense. But before I will dive into the questions, I would first like to take a moment to congratulate you on the amazing work that you've put together. Also, a great word of congratulations to the supervision team, Gilbert, Lars, and Roald, for supervising you in this amazing work. And I think your family, who was a big part of your PhD journey, are maybe the last, but definitely not the least, to congratulate you. And I'm sure you will find time together to celebrate it, how you should celebrate it. So I'm gonna do it a bit more traditionally, conservatively. I don't bring slides, but I'm a bit more old school, so I printed your thesis. And I chose the same colors as the school here. But you can find some structure in my questions, because I would like to go with you along the why, how, and what for your PhD thesis. And you can think of these questions of first, why? So why did you choose specific topics, methods for your PhD? Also, how should we interpret your findings so that we can use them in the future? But the most important thing what I would like to discuss with you is, what is this going to mean for clinical practice? And I think today we're standing on opposite sides of each other, but I think during this discussion, I think you could also see it as us standing next to each other and discussing how the future of the orthopedic practice should look like. But before that, I'm going to start with the why questions, and I think I'm going to start simple. So what we didn't discuss yet is, why did you choose the ACL topic?
So I was fortunate, after finishing residency in Winnipeg, to have the opportunity to come and spend a year in Oslo and work with Lars and the rest of the team. Many of the people I worked with are here today, which is awesome. And so the first thing that Lars assigned me to do was a registry chapter for a textbook that he had been asked to put in. And so in the course of putting together that chapter with Andreas at the back there, I learned a heck of a lot about the registries. And although I had known about the studies that had come out of there during residency, actually getting to travel to Bergen and meet the team out there, and the voyage of putting together that paper, I saw the value in registries where we're at right now. And during my fellowship, I think I was probably 90% knee surgery, so that was primarily my focus. When I left here, I went to Mayo Clinic for a second fellowship, and that's where I got to meet another colleague who's here, Ayush Parikh, who was a resident at the time, and he introduced me to the concepts of machine learning. And just sitting, having some discussions, it raised more questions than answers, but kind of putting the two together, a large data set with this novel approach, novel technique, really just seemed like a natural next step in my academic journey, I would say. So I'm a clinician first and foremost, but I have developed the disease, the research disease, where I have some questions that I want to answer. And the question started off as, can we more accurately tell our patients what to expect after surgery. And so this journey started not as a PhD journey. I didn't set out to say, I'm going to get a PhD by doing this. It started as, let's just see what we can find. And so we traveled, spent some money that others gave us, and started working towards getting some of these answers. And then when we started looking back a year, 2 years into it, we thought there's something here that's kind of greater than the sum of its parts. And so to be able to put it together in a thesis and really share the journey, and as well as kind of that vision for the future and where it's taken us in terms of where I think the registry is headed, is kind of just the next steps to that journey.
Yeah, and then in your title you say, well, we're going to talk about machine learning, but also reading through your articles, you end up choosing also what you mentioned, the logistic regression algorithms. So do you think then machine learning is still the right term, or do you consider logistic regression as a machine learning method?
Yeah, so the logistic regression we use, the Cox lasso, is still considered, well, so logistic regression itself is considered a learning technique, but the lasso aspect allows that feature selection, so technically it is machine learning, although it is kind of that machine learning light, the closest to that traditional statistical approach. So yeah, I would still consider it machine learning in the sense that it was a novel analysis compared to the traditional approach that most of the papers that have emerged from the registry have used.
Yeah, so it gave you a bit more flexibility in the algorithms that you used. Okay, and with that I would like to move to some of the model performance metrics that you also used. And I think during your thesis and also in your presentation you are also able to critically look at the results, specifically looking at calibration metrics. But can you share a bit why you chose to focus on discrimination and calibration for the two performance metrics?
Yeah, so coming into it as a clinician, I didn't know how we should be evaluating measures, and any paper you read, there's many different ways to report it. But that's where, relying on my team around me at the University of Minnesota and having these discussions, we asked and tossed around the different outcome measures we could report. And what it boils down to, which was reaffirmed by the tripod guidelines, which I eventually found, were that any machine learning paper or AI paper should present a form of discrimination and a form of calibration. Any other metric that is out there is either a modification of calibration, a modification of discrimination, or some composite score that somehow incorporates both. And we thought it would be, again, as more foundational papers, easier to present, easier to understand, easier to appreciate and critique, presenting each one separately rather than a composite score, because some of those exist out there.
And do you find one of the two more important than the other?
No, I would say that you need to have appropriate. The appropriate is the part we don't really know yet based on the clinical problem. You need to have appropriate discrimination and appropriate calibration performance to be clinically relevant. You can have a model that is very accurate at discriminating and telling patients who is higher risk compared to others, but if the risk estimates are way off, it's not really that useful. And vice versa, if you can dial down and give everyone the same risk score, you'll have very good calibration, but you'll have very poor discrimination, so that's not useful either.
Yeah, and in the case for the predicting a revision, would you then optimize on discrimination or calibration?
Pardon me?
So if you optimize on the predictive task for predicting a revision after an ACL reconstruction, would you then more look at discrimination, because that's what you maybe mentioned is more important for specific tasks, or which model performance would you optimize for?
Yeah, so if we use right now as a baseline, what I would like to see perform better would probably be the discrimination, because the models were well calibrated. The problem is that one of the problems you see with these sort of models is you can improve one, but it might come at the expense of decreasing the other, so you're limited by the data.
Mm-hmm. Okay, and as my other opponent also said, I'm also just a simple doctor, so I would like to also have you guide me in some of the performance outcome measures. So you mentioned in the first article we were not looking at the confidence intervals from our discriminative performance measures, but I focused more on the chapter 4, 5, 6. So by that time, you were able to report on the confidence intervals. And I'm not sure if you have the book in front of you, but I can. There was one thing that I found very interesting, and I can talk you through it.
Okay.
So when you were able to report the confidence intervals, I saw in your external validation paper on the stability trial that one of the confidence intervals included 0.5 to 0.7. And then I wondered, isn't then the prediction model as good as flipping a coin?
So the confidence interval basically tells us that the model performance, true performance, is somewhere in there most likely. So it could be as bad as flipping a coin if you get approached 0.5, or it could be as good as 0.7, whatever that number was. And I don't have the numbers in front of me right now. I thought for the models that we had chosen, the Cox model from the revision prediction model, that confidence interval was somewhere between 0.63, maybe 0.64 on the lower end, not all the way down to 0.5 something.
Yeah. Then that's maybe a good discussion for afterwards. So with that, I would like to also move more towards, so how can we interpret some of the findings of your papers, right? And for this, I also asked some of my friends who had some ACL reconstruction surgeries. So I happened to be in a tennis team, and two of my friends actually had an ACL reconstruction last year, and one of them is currently 32 years old, and the other one is 22 years old. And I asked them, okay, next week I'm going to Oslo, and I'm gonna ask some questions about prediction models. And I let them fill in the calculator, the revision calculator from which was externally validated in chapter 4. And what happened there is, so they end up having the same, surprisingly, the same Q scores and the same surgery techniques. The only difference was the change in age. And we saw that age is considered a risk factor for the revision. But what we saw there is that the older person, so the 32-year-old, she had a 5-year revision risk of 3.6, and the 22-year-old had no, the other way around. So, and the 22-year-old had a revision risk of 7.4%. So then I asked them, what do you think of these risks? So the 32-year-old said to me, okay, so I have a 3.8 risk, and my younger friend has a 7.4 risk. So that means that she's 2 times more likely than me to get a revision, that she's going to need a revision in the future. The younger person said, okay, well, 2 times as big sounds pretty big. I think it's just a difference of 3%, so I don't think there's a big difference. But when I looked in your thesis, I also saw that you considered somewhere in the range of 3% considered a low risk, and someone above 7% considered more a medium of a high risk. So we were discussing what do these percentages mean? So can you help us if you would have these 2 patients together in your office and they are discussing with you, what does this percentage mean?
So not knowing which graph choice they use, for example, in the different variables, I think that it just helps some patients to conceptualize the discussion regarding our treatment options. So someone who is low risk, I would have a much higher threshold to add adjunctive procedures like a lateral extraarticular tenodesis, or probably, honestly, in a primary setting would pay very little attention to things like tibial slope or other risk factors, where the patient who comes in and maybe has that moderate risk, maybe you start talking to them more about their goals. You know, are you going to go back and play tennis? Are you going to do other pivoting sports? Guide the discussion in terms of graft choice, other procedures. Maybe pay other attention to some of those other factors that aren't included in the model, like tibial slope. Maybe spend a little more time espousing the importance of proper rehabilitation prior to return to play. At the end of the day, we are pretty good right now at classifying patients over the age of 30, 35, 40 with an ACL reconstruction as being lower risk. We probably don't spend as much time talking about some of the importance of some of those other factors with those patients, where we might spend more time with those medium or higher risk patients. Certainly the higher risk patients spend more time talking to the patient or their family, their parents, for example, and might make some changes to the clinical care based on their recognition. And you also get, I think, maybe a little bit more buy-in from patients, because that 22-year-old might come in and say, well, my teammate just had an ACL reconstruction with a hamstring. Why are you telling me I need to have something else, either an LET or a different graft? Like, why? And you can kind of conceptualize and say, look, you are higher risk for these various reasons. And you can tell a patient it's because of your age and your activity level, or you can show them. And I'm not advocating to use this clinically to show them at this point, because we aren't there yet. But that's kind of the vision, is more of that visual representation of what we know in here, but the patients sometimes have a hard time conceptualizing.
Yeah, so then you use it more as supporting your conversation with your patients. And so as I mentioned, I focus more on the external validation papers. And can you quickly summarize again, why do we need external validation?
Yeah, so prior to any clinical implementation of any novel machine learning technique, prediction tool, whatever it's going to be, you have to show that the accuracy holds up when applied to preferably the target patient population, but at a minimum, the population different from the population that it was trained on. So our data was from 2004 to 2018, and it performed this well or this poorly, depending on how you look at it, with these patients. But if we wanted to apply this in Denmark, then we should see how it applies to patients from Denmark before we would actually use it for clinical care. Part of it was also an academic exercise, a methodological, rigorous exercise, and that kind of foundational, let's demonstrate the proper approach to this problem, because one of my personal pet peeves is if you go to the literature right now, everyone is just putting out paper after paper after paper saying, look what I can do. I can use machine learning to develop a model. But very few are externally validated, which just means people are putting models out there without really going that next step to show whether it's useful or not.
And what if I state there's no such thing as an externally validated prediction model? Would you then agree or disagree with me?
I would disagree in the sense that it may not be clinically relevant, but you can still assess the external validity by testing how the model performs in a different patient data set.
Okay. And then I would like to also understand your view on the following. So do you think in the future we need to have one prediction model that works both here in Norway and in Denmark, in the US and Canada? Or do you think we will end up with various local validated models that work only in the hospital here?
That's a great question, and has been the topic of a lot of debate and discussion. And the general, I'm not going to say consensus, but maybe the trend right now is to find methods that work specific to your patient population, pathology, whatever it is. And if you can demonstrate that the method itself holds value and can predict using these approaches, then you actually apply them to more of a local setting where you use the data institutionally or surgeon-specific or region-specific or whatever it's going to be to train, validate, and apply the model. Because at the end of the day, how does a model generated on a population from Norway apply to the patient in the most experienced high-volume surgeon in the country versus someone who does one ACL every 2 months, ACL reconstruction? So the advantage to the nationwide cohort is that generalizability. It's a good general assessment, but it doesn't necessarily apply to individual practices. So in the future, I do think it'll be more devise methods that work and then figure it out locally to how it's going to be implemented.
Yeah, so if I understand you, we are using external validation to assess the generalizability more as a whole, but that there's still a local validation step needed before you can move to implementation.
I would argue even more so than a local validation, although that would be useful to basically say whether it works or not. It's more show that the model works and then just retrain a new model using the same method, same approach, using more of that local data. Mm-hmm. So it's almost like you go back to the beginning and retrain it more locally once you have that accepted methodology for that specific problem. That seems to be the argument being made that I've come across in the literature the most. But if you have a model that works, and then you externally validate it, and it works on that local population, you probably don't need to retrain it.
Okay, so that's so it depends a little bit if you're gonna retrain it or only validate it.
Correct.
Okay, and with that, I'm also gonna use some of your quotes in your thesis. So one of your quotes is also the work is never done. So I'm curious, what should be the subsequent steps after the work that you have done?
Next steps, I would say, are primarily to see how the model performed on the data over the last 5 years. So since the data that was used to train and test the model, how did it do prospectively? See how it performs compared to surgeons to really kind of dial in and figure out how well surgeons are at baseline, how well can we predict outcome, and how does it compare to that? And then essentially, I think down the road, once we have more variables in our registries or databases, whether that's aided by AI or just by changing the registry data collection right now, see if we can make these models any better. The fact that it's never done refers more to that multi-billion-dollar question, which is, how do we ensure ongoing monitoring of not just this, but any clinical application of AI? And there's a whole massive grant program, Precise AI, which is looking to figure just that out, right? We don't have consensus. There's no out-of-the-box solution to determining what constitutes acceptable performance, what constitutes an acceptable decrease in performance over time before you have to retrain. How do we monitor these? In the future, maybe reinforcement learning comes into it more, and we haven't talked about that as the third pillar of machine learning, but reinforcement learning, which is used to kind of use penalties and rewards as a system of training a model to maximize rewards and minimize penalties in an ongoing basis learning environment, might be some sort of tool we use in the future for these sorts of models. But right now, we don't know. But we do know that what's important is making sure that whatever we develop and use works tomorrow just as well as it works today.
Yeah. And so you tipped upon the topic of reinforcement learning. If I heard that method, then I always like to also think about the current hype around agents. So are you already a little bit up to date on the agentic hype?
Not at this point, no.
Okay. Then I will not dive too deep into it, but I think if you have these prediction models, you can see it already as an agent. So a ChatGPT is a agent, a prediction model is a agent, and hopefully in the future we are able to combine all these different models in the backside of our electronic health record. But what you also mentioned is, okay, we want to compare how the AI model is doing compared to our physicians. But then it seems to me a little bit like it's us versus them. So are us doctors performing better than the AI model? And if we then move to clinical practice, so how do you think the synergy would look like between an AI model and a healthcare provider? So can you take us along when the model is gonna show you a prediction when you are currently in your patient conversation?
So phases, the work is never done. So the next step, let's see how the model performs compared to the surgeons. If, and there's a lot of if-then statements, right? So if the model underperforms, surgeons are better, then the model is not clinically relevant in its current term, or form, I should say. We go back to the drawing board, we collect more data, we use different variables, we try to develop new models that are better than us. As soon as you have a model that is better than surgeons, that's where I think it makes sense to investigate the symbiosis and the synergy between the surgeons and the models, where you can give surgeons access to the model prediction and then see how they're going to maybe change their predictions or decision making given that information. And then you can actually compare that accuracy, how does the surgeon perform in synergy with the model compared to surgeon alone or model alone. There's less importance in comparing with surgeon alone if we've already established that the model is superior. So you kind of just want to continue to test with the best performing existing model.
And do you then think that after those studies that also the trust in these AI models will increase?
If it shows superiority. So there are some models that perform better than the synergy between the surgeons and the models, and there are some models that the synergy is better, and there are some models that just aren't clinically relevant because the surgeons are better. And I think only by proper rigorous approach and showing those comparisons can we really get to that point of trust. We're not there yet. I don't think there are very many models out there right now that we as surgeons trust, and probably even fewer that patients will trust.
And what do you think is needed to increase that trust if healthcare providers need to use AI models in the future?
The other part is value, and we haven't really talked about value because we talk about clinical relevance and accuracy in terms of quantifying someone's risk, but does it matter? That's a whole nother kind of discussion we can have and really pinpoint which outcomes are really worth focusing on. Should we focus more on predicting who's going to have a revision, or should we focus more on who's going to tear their contralateral ACL, or should we focus more on the outcome of patient acceptable symptom state or return to sport or death, right? There are other outcomes that are maybe more important than revision surgery. And so this is the other existential crisis with doing a thesis like this, is we do all the work, but does it really matter? And we don't know yet. In general, I think that accurate prediction is hugely important, whatever that outcome is you're trying to predict, because it sets a stage to more clearly and accurately define patient groups that are maybe different risk categories, and then you can evaluate treatment differences within those groups. If you don't have the ability to accurately estimate risk as a starting point, you'll never really be able to see if someone can have an accelerated rehab protocol versus not, or other treatment effects. So the foundation is that accurate assessment, but we just don't know if we need help with that yet or not, because we're pretty good, right? We can identify patients who are high risk or low risk. So again, the value, is there a difference between a few percentage points between my predictions and the model? Does that matter? Probably not as much as if the model is very accurate identifying groups of patients who are high risk that maybe I am not as adept at picking up on. Time will tell. We really need to tease this out over time.
Yeah, and so you also mentioned, okay, maybe we need to look at other outcomes instead of revision as an outcome. So in part of my work, we try to predict revision in arthroplasty surgery, similar in register studies. And we actually came to the conclusion that for our patients, we are not able to develop an accurate prediction model because it is so difficult to predict revision, which is difficult to capture in the current register data. But now in the Netherlands, so we did our studies on our Dutch arthroplasty register. And now since this year, we are also collecting the ACL patients. So now that we're starting a new registry, can you maybe help us what kind of variables we should collect so that we are maybe able to predict revision for these patients in the future?
Great question. So ISACOS actually has a working group that we're working on, kind of that minimal universal data set that everyone should capture. Even then, the problem is minimal is really minimal, right? So there's the minimum variables that should be captured by a registry to track some outcomes, but that means that you're going to have other variables that you really want that aren't going to be included in that minimal risk. I think the Norwegian registry in its current form is a very good template to follow. The more we collect the same variables between registries, the more we can collaborate and really develop strong models or studies from the combined collection of lots of patients. But I also would look at the limitations of the current registry in the light of the current evidence that suggests there are other variables that aren't being collected that are of importance. And things that I would be very interested in collecting that we aren't currently are things like tibial slope. If you can dial in on rehab factors and return to sport goals, that would be great. Hard to capture because those are more subjective from the patient. But at a minimum, we know the high-risk things that are in the registries already. We started capturing lateral extra-articular tenodesis in 2018, I want to say, which is a good value add. I think osteotomies for tibial slope correction as a surgical procedure. And then, yeah, tibial slope, I'd say, would be the biggest one. So kind of, there's a minimum set for everyone. I would say the Norwegian current registry, which is very similar to the Danish and Swedish, represent more of that ideal, but the true ideal would be capturing everything that we currently know is a risk factor.
Yeah, and what you also presented, so adding additional data, so for example, imaging to your registry. Do you think the infrastructure is already there to connect different databases for our registry?
I can't speak to the Netherlands, but it's not there at this point for the Norwegian registry, which is one of the discussion points we have when we sit down and chat about how we're going to pull this off moving forward. And it's going to take work. It's going to take getting a lot of people on board. We kind of look at it like an opportunity to kind of lead the way, because a lot of the other registries aren't necessarily going down this road yet. And so if we can be the first or work with some others to become the first registries to really integrate all of these components, then it serves as that blueprint for how it can be applied to other registries, whether it's musculoskeletal or medical or other registries. But as of right now, it would take collaboration between the health system, the patient journal, electronic health record, radiologists, the imaging departments, and the registries. Everything is right now still kind of siloed.
Yeah, and do you think it's siloed because of the technological challenges or because of human factors?
Probably both. I think partly geographic. The registry is located in Bergen, and maybe the DIPS, which is the patient record, probably has locations throughout the country. Different hospitals use different patient records, so they're not all using the same one. So that's another hurdle to try to overcome. I think there are a lot of barriers, but it just means they need to be identified and solutions need to be worked out. So it's a challenge, but I see a path forward.
Okay, and also in your thesis, you touched upon the bias, and you also presented that in your earlier this morning. And you said, okay, there are some known biases like gender biases or maybe other class biases. Do you think it's also possible that orthopedic surgeons have a certain bias which was introduced in the register that we are maybe not aware of?
I think surgeons can bias the data in a number of ways, whether it is selective enrollment of patients. I don't know why there are 5 to 15% of the population not enrolled. I don't know why those patients aren't being captured. I think some of the treatment decisions could be maybe biased by the surgeons based on where they work, the type of patients that they see. I think certainly the outcome tracking can be biased. Patients either of certain socioeconomic status or occupations or gender, race, ethnicity might be more prone to have a revision than not, or might be more prone to answering the follow-up patient-reported outcome measures than not. Language can certainly play a role in that as well. So there are a number of ways you can have bias in the data that you're collecting. And certainly the surgeon influence there with the decision-making around surgery and the data we collect from surgical details can be prone to bias.
And how can we, if we have a registry data set, so how can we understand or identify if there were biases within our data?
That's more challenging because you have to, again, rely on what we think might be those biases and then look for them. It's hard to, and I haven't thought about this, it'd be hard to just ask a model to figure out if there are biases. Maybe there is an opportunity there. But at this point, you'd kind of have to look and say, all right, we think there might be a bias of this sort, and then you have to dive into the data and look, are there more people of this ethnicity that respond and fewer of this group represented in the registry? Especially if you're talking about a Norwegian registry, I mean, it's a very homogeneous population here, largely white, Caucasian, Northern European descent. But there are also a lot of recently immigrated people to this country, and are they represented in the current registry or not? Those are questions you'd have to dive into and look at.
And does it then help to also what you did in your chapter 6, the clustering chapter, that you look at different subgroups from a data set and identify maybe the differences within those subgroups?
You could do it through an unsupervised learning approach. I think to really get after the bias would probably need more intention. You'd probably need to try to identify those variables that you have and seeing if they are individual biases in terms of the proportion within each group that you're looking for. Whether that's all patients, those with the revision, those with follow-up data, whatever it's going to be, determine if there's a difference in the population or proportion in each one.
Yeah. And do you think there could also be bias introduced because of the differences in healthcare systems, what you already mentioned, that maybe how we treat patients in Norway is different from how they are treated in the US or Canada? So how can you correct for differences in healthcare systems?
Yeah, no, absolutely. That's a great point. I mean, even just seeing, look at Denmark versus Norway, much higher rate of hamstring graft in Denmark than in Norway after 2014. And this just comes down to developing models, I think, with the methodology that works, and then you have to train it on more of that local data, because the practice patterns can impact the accuracy.
And do you think that there also may be like financial considerations per country, why certain treatments are chosen more in one versus the other?
Yes, I would say that I've probably seen that in terms of training in, I kind of look at it like I've trained in 4 different countries, right? I've got Canada, US, Norway, and Mayo Clinic, which is kind of its own entity. But you can see practice patterns are different, and certainly financial constraints are one driver of those changes. Constraints or opportunities, you could say. More socialist healthcare systems, like the Canadian and Norwegian systems, are oftentimes more cost conscious in terms of the implants they use or the approach that you follow. I would say also probably more likely to be evidence-based, more likely to see, less is more approach, or more with less, and also what is the right thing to do for this patient, as opposed to, and this is a generalization which, hard to really quantify, but doing things above and beyond that minimum acceptable standard just because you can or have access to it.
And with that, I would also like to go back to the next steps that you're taking, because also what you say in your thesis, you're laying the foundation for future work in this field. And we already agreed that after external validation, we're also going to do a local validation before we're going to the pilot phase. Do you think, if you're going to do that practically, do you think it will get quicker off the ground here in Norway or in Minnesota, where you currently work? So which location would you first use to pilot one of your algorithms?
Based on the fact that the models have been developed and validated, all the work has been done here, and I've established such strong relationships, I think that it just flows easier here. So if my colleagues will continue to work with me, I would love to continue this collaboration here. Just because there are different barriers working in the United States as well. There are wide differences in patient populations, and it would be really starting from scratch. And the other part is just the availability of good quality data. We were chatting earlier about, in the American healthcare system, there is no national register, so you're largely identifying patients retrospectively using, coding, ICD-10 codes, procedure codes in the health record, or through insurance reimbursements or submissions, and that's prone to bias and error in itself as well. So I think starting with more of the system we have developed here at accurately identifying patients and developing, again, the methodology that works, if we can get it dialed in here, I think that creates that blueprint again that would be more likely to be applied somewhere else. I think if I was still working in Canada, that's another area that would be a little bit easier to pursue than the United States, just because of differences in the health system.
And so I assume that you will be part of the follow-up studies. But what if you're handing over your algorithms? What are then some of your biggest concerns with the current algorithms you developed if they're going to be piloted here at this location?
Concerns would be over-reliance. I think that's certainly any time you have a novel technique, it's still incumbent upon the surgeon, the end user, to recognize its limitations and possibilities. So understanding that it's a tool and that it is, again, still not proven as being clinically relevant, we'll say, that I would not make treatment decisions based off of an algorithm at this point. But hopefully we get to a point where these algorithms have shown clinical relevance where they can help guide those clinical decisions and discussions.
Yeah. And since you're going to pilot then the algorithm first here in Norway, so here in we also have the AI Act. I'm not entirely sure if that's also in Norway, but the AI Act also states that every person that's going to use AI needs to be AI literate, starting February this year. So what is your view on how the orthopedic surgeons of the future should be educated in using AI in their clinical practice, and where's the responsibility in a university or in a government to become AI literate for the doctors of the future?
Yeah, that's a big topic. I mean, it starts with the early education, everything from medical students through residency, practicing surgeons. We have a few AI working groups within orthopedics. We've managed to put out, I want to say, close to 20 publications now that kind of serve as that baseline background reading that should be part of an educational program. I think that educational programs should incorporate a lot of this into their journal clubs, their critical review of the literature, and just become familiar with the terminology and the, what does it mean, how to interpret the results, what's a good study, what's a bad study, how does this apply to our patients. And so I think being AI literate is hugely important. And so, a lot of colleagues that I've worked with largely across Europe have really focused on trying to bring up the general level of knowledge and understanding amongst our peers.
Yeah, and I think, well, you're always humble, but that's also in the work that you're doing as an AOS representative in using AI. So I think the Orthopedic Society is also counting on you to guide us further in how to use AI in the future. I'm also going to look at the time. How much longer do I have? Okay, that's good. That's good. Then, because I have a long list of questions for you, so I'm going to pick a few to focus on. That's good. Okay, so the education question, that's quite a large topic to cover in 10 minutes, so I will skip skip on that one. So I would really like to philosophize also with you in because I have challenges myself in setting up these pilot studies. So how should we practically do it? So would you say we're going to use an algorithm, run it in the background, and have first the orthopedic surgeons predict the risk, and then look 1 to 5 years later what the actual risk was? Or how do you practically see these pilot studies flying off?
So we currently have a pilot study going on for the TARO study as we apply for federal funding. The current administration in the United States has hampered our ability to apply for funding for international collaboration studies. So as of right now, we're just proceeding with the pilot. So for this study, we're essentially collecting the variables that all of the machine learning models that are published, that we're aware of, require for outcome prediction. And we are asking surgeons to predict. We've chosen 3. I'm going to add a 4th outcome when we do our actual study. We're predicting revision surgery, achievement of patient acceptable symptom state. So are you satisfied with the result of your surgery, yes or no? And then a functional testing question in terms of, I can't remember the exact verbiage, but are you limited in your ability to be active or participate in sports due to your knee? The 4th one I want to add is, what do you think this patient's chance of a contralateral ACL injury will be long term? And so we're asking the surgeons to quantify their estimate of the patient's risk, and then we are following these patients. And it's a low burden study because all we need from the patients is the permission to contact them, at certain time points down the road and ask you, have you had a revision? Are you satisfied? Have you torn your other ACL? And are you limited? So patients are signing up for the study very easily. It's not like some other studies where there's a lot more hesitation. But that's kind of how we've envisioned it right now is the model is going to be run, or the models will be quantifying that risk based on the variables we're collecting, and then comparing that with the surgeons. And then the surgeons are going to be, compared kind of amongst themselves. So testing amongst themselves where their performance compares with the model, because you might find surgeon A will have all of their, we'll choose one parameter, revision risk predictions between 3 and 6%. You might have surgeon B, all of their predictions are 6 to 9%, and surgeon C might be 4 to 14%. So you're going to see a wide spread, and that's where our statisticians has kind of run some simulations to give us a target patient population. And if we can get an average of 50 patients per surgeon, that will allow us to hopefully, with a small confidence interval, make some inferences regarding the accuracy. It's an ambitious study. Like the big study we're looking for is 2,500 patients. So it will take a lot of collaboration. But we're starting with 200s, and it's going well so far, I would say.
And so you mentioned that you also want to collect it retrospectively, but also prospectively. So do we then need to wait 5 years until we get the first results, or how?
Yeah. So the question is not inherently, can a machine learning model interpret retrospective data better or worse than we can? So we're not asking surgeons to look at 50 patients from the last few years and give them the information and see if they can interpret it as well as a machine learning model can. That doesn't make sense, because that's not what we do in clinical practice. Because as we talked earlier today, surgeons have so much more information available to us that's not available to the model. Discussions with the patient, the Looney factor, all the other things that play into it. And so this is going to be a prospective study that we will not have an answer for several years down the road. But at the same time, we will also perform a retrospective prospective analysis, right? So see how the model, if we had started using it in 2019, how would it have performed over the last 5 years? So we'll do that kind of now at this stage while we collect surgeon predictions and figure out, hopefully in 5 to 7 years, how we did.
And when would you say it's good enough?
Well, if the model is better than we are, then it holds value. Future models can be compared against that model to see if they're better or worse. And of course, the model would then, multi-billion-dollar question, need to be checked to just make sure it doesn't drop off in terms of performance long term. If the surgeons are better or the same, then we have to look at starting from scratch, probably a few years down the road, when we have more different variables, different data to test, because that suggests that right now the models hold no value.
So if I understand it correctly, the better our surgeons are, the less we need AI.
At that point, yes, but that doesn't mean that we would never need it, because I still think that AI is a tool that could help us down the road. Now, I mean, hey, if surgeons are AUC of 90 or a concordance of 90 and very well calibrated, That's going to be a tough bar to surpass. Not to say we shouldn't try, but if that were the case, I'd probably focus my attentions on a more pressing problem or question. Maybe, MPFL, reconstruction, patellar instability. There's so many other problems that this could be applied to. We're just kind of starting with ACLs.
Yeah, so my questions kind of slipped. So, okay. I had a follow-up question, but I will leave it for that. Yeah. Okay. So your first step is to identify the risk prediction for revision among surgeons. Then look how the difference is between the AI model, and then look if you can implement it further into practice.
Yes. So run the model on the same patients the surgeons are predicting. Compare to see if one is better than the other one or if they're equivalent. A further step based on the results of that could be a symbiosis assessment, which again is another prospective study to see if the combination of surgeon with the information of the models is actually the best or not.
Yeah. Are you then also going to test the moment when the risk prediction will show up? So if a healthcare, if you're in the room with your patient, that you first try to predict it yourself and then have the model, or do you want to first have the AI model showing you a risk prediction and then confirming it as a healthcare provider? Which of the two do you think we're
Part of that we'll hopefully learn from the TARO study, because we're asking surgeons to make predictions at 2 time points. And we chose the time points of after the patient has been seen in the clinic and you have the discussion about surgery. So you're in, you have a torn ACL, we talk about your goals, your knee, your risk factors, the graft choice, make the surgical plan, review the imaging. At that time point, I probably know the patient better than I ever will, because I'm going to see 20 more patients that day, 100 more that week, do many more surgeries before the day of surgery. I'm going to forget. But at that point in time when I'm in the clinic, I can make those predictions because I have that information available. Then I'm going to go and I'm going to do the surgery. Maybe it's weeks, maybe it's months down the road. At that point, you look back and you refresh your mind, you refresh your memory in terms of, oh yeah, this patient has a meniscus tear, I'm planning this, and oh yeah, we talked about that. You probably don't know them as well as you did in the clinic day, but you walk out of that operating room and you have that, I call it the X factor, right? Sometimes we don't like to admit it, but as surgeons, when we walk out, sometimes we go, nailed it. Sometimes you walk out and go, oh, Jesus. So it's that side of it where you can probably glean some more from the surgery at that point and say, I don't know how this patient's going to do. Like, that graft did not feel that well or feel that great, so it didn't feel that solid. Or sometimes you say, that was rock solid, high fives all around, let's go. And so if we ask surgeons to make another prediction at that point, we can also determine the time point at which surgeons have more accuracy, right? Mm-hmm. Is it more that factor of after surgery, you have the best, I know how surgery went, therefore that's how this patient's going to do? Or is it, I understand the patient, I haven't done the surgery, but I've made my surgical plan, is that when I'm most accurate? We're also interested to see how predictions change. So we're going to give the surgeons to say, look, you predicted preoperatively, this was your risk score. Now that you've done the surgery, how do you feel? Right? Are you going to change it up or down? And so seeing that difference from point A to point B will be interesting too.
Yeah. And so I'm going to end with a final question, and the answers you will give me, I will write them down. And since you're living in America, I invite you to think big. So my final question is, we tend to overestimate the progress we can make in 1 year, and we tend to underestimate the progress we can make in 10 years. So what is your vision for how far we are currently with the progress of your work in 1 year, and where will we stand in 10 years from now?
That's a great question. Yeah, and there's so many parts to unpack there too, because we have so many different concurrent changes going on, whether that's the changes in the registry, the data collection, the actual investigation of the clinical relevance. So a 1 year goal from now would be to be close to, if not attained, funding for a larger TARO study. And I think by also within a year, we should be able to find out how the model has performed over the last 5 years. And really, I would say, have a plan in place to see how we can evolve the national knee ligament registries, both in terms of ACL, but then also patellar instability. And so I think that a reasonable one-year timeline, so if we look, June 2026, we should have those plans in place and a pretty good vision. 10 years? 10 years, I think I would hope to see some changes in the registry. We may not have achieved the registry 2.0 as I put out there this morning. But I do think that we should, over 10 years, with resources and motivation, execution, we should be able to incorporate a lot of the changes we're looking for. At a minimum, if we're able to incorporate more automated image analysis and pull some of those values that are not currently in the register and include them, if we can lighten the load for surgeons, I see that as a very reasonable goal within 10 years to say, instead of duplicating work, dictating an operative report, and then filling out the same information, you dictate your operative report, it goes off to the registry, and they pull that data automatically, and then you just fill out a few data points, and then maybe the registry reaches out to you to clarify a few things. I think that's a reasonable goal within 10 years as well. I honestly don't know if this is going to be any sort of clinical relevant model in 10 years, because I frankly don't know how good we are as surgeons, and I don't know where that benchmark is to say that something is valuable or not. By 10 years, hopefully we'll have an answer to where that benchmark is at least.
I hope in 1 year and 10 years from now we can look back at those visions. No further questions from my side. Thank you for the discussion.
Thank you.
So thanks are due both to the candidate and the examination committee. The examination committee will now leave the room to evaluate the dissertation and make their final decision. I ask for the rest of you to stay in the auditorium, and I will announce the committee's decision within 5 to 15 minutes, so just stay.
I'm ready for a drink. Thanks.
Okay. Excited? No. So, the examination committee has found Kyle Martin's dissertation of June the 4th satisfactory. The committee conclusion is unanimous. On behalf of Rector of Norwegian School of Sports Science, I hereby award Kyle Martin the degree of Doctor of Philosophy, PhD in Sports Science. Congratulations. And if you have the chance to come back in August, you will receive your diploma in the ceremony at the start of the next academic year, if you have the possibility. Otherwise, you will get it some, yeah, anyway. Then I will ask the committee and the new Doctor of Philosophy to join me in a procession out of the auditorium, and I hereby declare the disputation for completed.